and I'm pleased to welcome you to today's event. Before we get started, I'd like to give you a little bit of background on Advize Health. At Advize, we analyze processes, implement solutions, and deliver quality educational opportunities for healthcare entities of all sizes. We offer an extensive catalog of services, including HIPAA and compliance analysis, medical documentation auditing services, and educational opportunities for a number of specialty-specific topics. The educational program you're about to view is just one of many services that Advize Health advisory sector has to offer. We provide the medical billing and coding community with 30 free CEUs per year through our monthly webinars and coding newsletter. Our priority and promise to the healthcare community is to always tailor our services to our clients' needs and budgets. We have two exceptional speakers for today's presentation, Dr. Robert Wah and Lisa Esch from CSC. Dr. Robert Wah is the former president of the American Medical Association. He currently serves as the Chief Global Medical Officer at CSC. Prior to his tenure at CSC, Dr. Wah was the first Deputy National Coordinator for Health IT at HHS. He also served in the U.S. Navy for 23 years in leadership roles for the military health system. Our second presenter, Lisa Esch, is the Chief Population Health Innovation Officer at CSC. She previously served as Senior Vice President of Health Grades and holds multiple leadership roles with Health One and HCA. Now for some general housekeeping items. Today's webinar will be an interactive presentation, and you will be asked to participate in polls during the broadcast. All materials required to fully participate in this webinar are provided through the GoToWebinar interface. If you have questions, please remember to send them to all organizers at any time during the presentation. We will periodically pause for questions. There will also be time for a brief Q&A when the presentation concludes. This webinar will be recorded and sent to all attendees along with a certificate for 1.5 CEUs within 3 to 5 business days. Now we will go over the agenda for today's presentation. Okay. Today, we will be covering a brief history of healthcare, as well as MACRA. I will now turn it over to Dr. Robert Wah to begin the presentation.
Thank you. Good afternoon, everyone. This is Robert Wah from CSC, where I serve as the Global Chief Medical Officer. It's a pleasure being with you all, talking about this important topic. I thought I may just start quickly with an introduction to CSC. CSC is an IT services system integrator company. We've been around for over 55 years, and we don't do a lot of marketing, so I joke sometimes that CSC may stand for completely secret company. It isn't necessarily a household name, but we do large-scale projects in all areas of industry, not just healthcare, around the world. So in healthcare, we do about 10 to 15% of our current company is focused on healthcare. So it's a significant portion of our work at CSC. And we do, like I said, nation-level projects. In healthcare, for instance, we had the contract to wire the National Health Service in the UK. So we installed electronic records in over 2,500 clinics across 2/3 of the country, and about 35 million UK citizens run on the electronic records that we install. We're now in the process of installing inpatient electronic records to about 121 hospitals across England. So it's probably one of the largest deployments of electronic health records out there. We also purchased a software company named iSoft, and it's the 4th largest electronic health record in the world. We have no footprint in the United States, but outside the United States, our records cover about 100 million lives around the world. So it's a very large enterprise that we have. I'm proud to be part of that for nearly 10 years. When I left my military and government positions at DoD and the HHS, I was looking for the same kind of scope and scale that I had in government, and I found that here at CSC with these large-scale projects that we have. The last thing I'll say is that, well, two things. One is because we operate in all industries, we're able to take the learnings from one industry and apply it to another. So in healthcare, we benefit from the work that gets done in cybersecurity and other industries to apply that to healthcare. One of our projects at the DoD was to create a single database for all the electronic records. So when I was at the DoD, I was very proud that we had a single database that's about 70 terabytes large. When I got to CSC, I found out that we also tune the MasterCard database, which is many, many, many terabytes, more petabytes larger than ours is. So they said, oh, that's a nice sized database that you had at DoD. So it's interesting to see what other industries have worked on that we are just starting to work on in healthcare. The last thing I'll say about CSC is that in May of this year, our CEO announced that we will be merging with Hewlett-Packard Enterprise Services. Hewlett-Packard has divided the company into hardware and services, and we will be merging up with the services component of Hewlett-Packard, which used to be legacy EDS. And so we told Wall Street in May of this year that by March 2017, the combined companies will have a revenue of $26 billion. Our CEO will continue to run the new company, and Meg Whitman, the CEO of HP Enterprise Services, will join our board. So we're in the process of rapidly expanding our scope and scale at CSC, and come March 2017, we'll be one of the largest IT services companies in the marketplace. So that's just a quick introduction to CSC. I hope it's useful to you. But we're here to talk about healthcare in general, and particularly all the activity that's happened at CMS. And so I'll start with a rather complicated slide that depicts where we are today in healthcare in terms of Medicare. As you know, Centers for Medicare and Medicaid Services, CMS, they have a large remit. They cover the elderly over 65, disabled people, and then Medicaid is the low-income healthcare insurance plan. So on this slide, the current state of healthcare, you can see some interesting statistics about how the cost of caring for this population is broken down. A great deal of the money that goes towards Medicare is spent on elderly patients that have chronic medical conditions. And so that is projected to be growing at a rate that's quite rapid, although it's slowed down over the years. And because this high amount of spending on patients with chronic illnesses is happening, one of the things that Medicare has put out, and we'll talk about later, is a special code to take care of patients differently that have chronic conditions. And it's called the Chronic Care Management Code, and we'll speak more about that. But it's just, on this slide, I'm just trying to show how large the spend is at CMS and how much of that spend goes towards elderly patients with chronic conditions. On the next slide, I just wanted to cover some of the goals of healthcare reform. We've all seen the headlines and lived through the changes. As you all recall, the Affordable Care Act passed in 2010. The major goals at CMS remain the same, which you see here. And that is better care for patients, healthier people, and then smarter spending, so we are decreasing the rate of rise of the spending on healthcare. It is obviously important for CMS, and I think all of us, as a physician, I align with these. I think my goal as a physician is to take the best possible care of my patients and do it in a way that is more preventative as opposed to interventive. So we talk about the prevention should precede intervention. We'd like to keep people from getting sick before they're actually sick. In reality, we've done a good job over the last 20 to 40 years of intervention. If patients get sick, we're pretty good at dealing with that, whether it be a broken arm, broken leg, an infection, heart attack. We have an acute disease system that reacts and takes care of people very well in those circumstances. Where we think the biggest opportunity, though, is to take care of those patients that don't get rid of their disease. It's not something that comes and goes. It's a chronic disease that they will always have. And so that is the challenge before us. How do we take better care of patients with diseases that they will never get rid of? Diabetes, hypertension, congestive heart failure, pulmonary diseases. These are things that people will live with for the rest of their lives. And the challenge is, how do we make sure that living with it is as optimal as possible and in a cost-effective and cost-efficient way. And so that's one of the major goals that we see in the Healthcare Reform Act, and it's always been a goal of the medical community to do that. In the next slide, I'll talk about how there's been a shift in the private sector and the public sector. And in the public sector, we mainly talk about Centers for Medicare and Medicaid because they're a large payer of care for the elderly and for the low income. And so it's been, well discussed that there's a shift from volume of care to value of care. So, fee for service, it's been likened to, it's a piece by piece payment. So the more you do, the more you get paid, as opposed to a value-based system, which is where good outcomes are highly valued and you get paid better if you have good outcomes. I will say here that as a physician, while I recognize this is a fiscal reality out there, my goal as a physician, like I said, is to take the best care of my patient. And I'd like to make sure that we keep balance when we talk about payment system reform, that we also should be thinking actually earlier about delivery system reform. So in my ideal world, we would craft a system that delivers the best care to patients, that gets the best outcomes in a cost-efficient and cost-effective way. And then we'd craft a payment system to make that delivery system work. The reality is we oftentimes fiddle with the payment system trying to drive changes in the delivery system. And that to me is not ideal, but I recognize in a very pragmatic way that we're not going to get rid of that. So I'm always trying to just reset the needle and the balance so that we talk about not only payment reform, but also delivery reform hand in hand. But as you see here, the current plan by the administration is to shift from volume of care to value of care. And they want to move first, 30% into quality and value, and they want to move that up to 85% in a short period of time. And so we all that are in the healthcare system must be aware of this significant change in the way payment will be delivered in care, payment will be made in the healthcare system. And as we also all know, the public sector, CMS, often leads payment changes in the system. So things that happen at CMS are often watched very carefully by the private sector. So the private insurers often are watching what CMS is doing and will take the successful programs and then begin to use those in the private payment system as well. So the things that we're seeing at CMS are often leading edge or leading indicators of what we'll be seeing in the private sector as well. So on the next slide, talking about CMS's quality strategy, CMS is trying to do several things. One is they recognize that with this high number of patients with chronic illnesses, that there's a big need for care coordination, because people with chronic illnesses are complicated and their care is often fragmented. And so they believe that there's a need for a coordination piece in their care that brings all the parts and pieces of the patient's care into coordination. And so it isn't so fragmented and so differentiated and siloed. Also, they're trying to promote a patient-centered care that's focused on the patient. It's often been said that patients sometimes feel frustrated that they're not seen as an entire person by the medical care process. They're seen as a sick kidney or a diseased heart, or a metabolic problem like diabetes, but they're not seen in totality as a single person. And so there's a lot of discussion about patient-centered approaches to coordination of care. And we all recognize in the healthcare system that there are huge positive impacts that will be had if we can achieve this better coordination and patient-centered approach to taking care of our patients. We've all seen examples where because patients are not seen holistically as a single person, that activities in one area, taking care of their kidney, may be in conflict or duplicative of somebody who's trying to take care of their blood pressure or their heart disease. And so that can lead to problems that are suboptimal for the patient, but also very costly for the system because of duplication of effort, multiple repeats of tests, or conflicts of medications and things like that. So this quality strategy, I think, is important from a number of dimensions. I think it will first and foremost lead to better health for our patients and hopefully also lead to lower costs for the system. So with that all as background, I want to talk about MACRA because I think that's what everybody heard as a key word for this presentation, and it attracted a lot of interest. We're very excited to have such a large number of people sign into this webinar. They tell us that the participation in this webinar is one of the highest they've had in the ones that they've done. So we're very excited about that idea. So let's talk a little bit about MACRA. But before we talk about MACRA, let's go just back one step. Remember that for many years we had a thing that paid physicians in Part B that was called the SGR, which stood for Sustainable Growth Rate. And as is typical here in Washington, D.C., the words don't seem to match the reality. So the SGR was not sustainable, it didn't grow over 12 years, and it maybe was a rate. But other than that, SGR really wasn't an accurate depiction of what was happening. Now, as was mentioned, I had the privilege of serving as the president of the American Medical Association, the AMA. And at the AMA, we fought for over 12 years to repeal the SGR because one of the things that made it very complicated was there was a, if utilization was high one year, then the plan was the next year payments to physicians would be cut to make up for the overage of the previous year. And the formula was very complicated and it got off track, and so we were soon facing double-digit cuts for physician payments. And the way the system worked was if Congress didn't act on January 1st of the year following the measurement year, a double-digit cut to physicians would be in place. And every year, for many, many years, Congress would wait until the last minute, like the last day or the last week of December, to pass some sort of a fix that would prevent the double-digit cut in payment to physicians the next year. This kind of craziness led to a lot of problems. Physicians could not plan their next year because they didn't know until the last minute, and often the last day of the year, calendar year, what their payment was going to be for the next year. So that made it very hard to do any kind of proactive planning as a physician. You know, if you don't know whether or not your revenue stream from Medicare is going to be cut by 10, 15, 18, 22% the following year, it's pretty hard to make plans for the next year where you're trying to improve the care for your patients in your office. So that uncertainty was a huge, huge problem. They never paid for these changes that they made every year because they put these patches in place. There were 17 patches in 12 years put in place. And then what happened was those patches never got paid for. There was a large bill, like not paying your credit card every month. You know, the buildup of the interest and the principal is really overwhelming. And so something had to happen. And so the AMA for many years pushed for repeal of the SGR, resetting the baseline. And I'm proud to say that when I was president, Congress finally passed the repeal of the SGR. So they had until April 15, 2015 to repeal the law. And on April 14th at 10:30 p.m., they finally got to passing the law that was going to repeal the SGR. I happened to be attending a World Medical Association meeting in Norway at the time, so I was watching live streaming over the internet of what was happening in Congress, but it was like 4:30 in the morning in Norway. But I was proud to be able to say, as president of the American Medical Association, on my watch, we passed the repeal of the SGR. Now, I can't take personal credit for that happening. It was the work of 12 years of effort of many, many people at the AMA and other medical organizations and industry that got that passed. But I was fortunate to happen to be the president when it did pass. So what happened after it passed? The new law was called MACRA, which stands for Medicare Access and Children's Health Insurance Program, PIP Reauthorization Act of 2015. That's how you get the 5 letters of MACRA, Medicare Access and CHIP Reauthorization Act, because the CHIP program was due to expire about the same time they were trying to repeal the SGR. So they did 2 things. They repealed the SGR and they reauthorized the children's program. So that left us with MACRA. And the idea behind MACRA was that they were going to consolidate some of the issues that they had seen in the current programs and streamline the programs for physicians. And one of the challenges was, you know, passing the legislation, as hard as that is just the first step. The next step is implementation of the new law. And so once the law passed, the regulators had to sit down and start writing the regulations that would follow the law that was passed. And so the law was meant to repeal the sustainable growth rate. It was also meant to streamline the many quality programs that are out there, things like PQRS, the value-based modifier, and meaningful use, which was for the use of electronic health records. It was also going to link payments for care more towards value and quality as opposed to volume. And then it was going to have a bonus system for participation in these new payment models. So that was the large top-level goals of the legislation. But as you can imagine, to implement that, it's quite complicated. I will also say that it was a bipartisan landslide passage of this law. You know, in the Senate it passed 92-8, and in the House of Representatives it was like 390 plus votes for this, and it was signed by the president very quickly. So it was an overwhelming majority. You don't see that in Washington, D.C. very often. Both sides of the aisle supported this. All houses of the legislative and the executive branch supported. So it was a program that many, many people wanted to see happen, and we were all pleased. But then the next step was the regulators had to sit down and start writing the rules, and that's where we are today. Those rules are complicated, and that leads to what we're talking about here. On the next slide, I think we're going to have a poll here, and the plan is to ask you all to use your electronic polling mechanisms. If you're all logged into the webinar, you can answer this question about how familiar you are with MACRA. So if you can all go and select the one that applies, we have 5 different choices. And we'd just be interested to know what the group that's listening in on the webinar today, what's your familiarity with MACRA today. So if you'll just take a moment to go ahead and do that, at a later time we'll be able to come back with you and tell you what the results of the poll are. I want to resume the slides if I can, and let's get into the details about MACRA. And this is complicated, so I'm trying to target this at the middle of the group. Many of you are very sophisticated about MACRA and know a lot about it, but we know many of you, MACRA is a new 5-letter word that you haven't heard before. And so I may be overly detailed for some of you and maybe under-detailed for others, but we'll try to hit somewhere in the middle. So one of the first things about MACRA is there are 2 tracks. that CMS has put out. Now, when I say CMS has put out, remember that the rulemaking process in the government is that there's initially a proposed rule that comes out, and that came out this summer, and it was about 1,000 pages long, and so the proposed rule came out, and then the CMS solicited comments. In other words, they wanted to hear what people thought about the proposed rule. So it was only about 988 pages we had to read through, and there were thousands of people that sent in comments. And then they took all the comments and created the final rule. And the final rule just came out in mid-October, and it grew from the 900 and something pages of the proposed rule to over 2,000 pages in the final rule. And so we've all been combing through the couple 100,000 pages of the final rule to sort out what this means. Now, one of the first and foremost things to know about MACRA is that the payment under the MACRA program is due to start in 2019. However, your payment that you receive in 2019 will be based on how you perform in the year 2017. So I'll say that again. Your payment in 2019 is going to be impacted by how you do in the program starting January 1st, 2017. That's just a month and a half away. So the game begins even though the payment doesn't start until 2019. The measurement for 2019, how you'll be paid in 2019, that starts in January 1st, 2017. Now the obvious complaint has been, how do you get ready to play a game that starts in 2017 when the rule book just comes out in mid-October of 2016? But that's the reality. Now, what CMS has done to face up to that reality is they've said that 2017 will now be a transition year. They also put out a program called Pick Your Pace that I'll talk about later. But just know that one of the urgencies here is that the payment for physicians will be based on how they perform starting January 1st, 2017. So it's critically important that everybody understands, even though the rule book just got published, we all have to get pretty smart pretty fast about what the game is going to look like starting 2017. So let's talk about this slide here, number 10. It talks about which track are you on. First, Medicare has said that there are two tracks you can be on. You can be on an advanced APM. APM stands for Alternative Payment Model. And so an advanced APM is defined here as one of these 5 things: a comprehensive renal dialysis program, the Comprehensive Primary Care Plus, CPC Plus program, a Medicare Shared Savings program, only track 2 and 3, track 1 does not count, a next generation ACO, or an oncology care model that has two-sided risk. That's not slated to start until 2018. So APM is a possible track for some people, but the vast majority of people are going to be on what we call MIPS, which is an incentive program, right? And this is where we think the vast majority of people will be. Now, in the final rule that just came out in mid-October, there was a lot of discussion about how CMS is trying to make it easier for physicians to qualify under the advanced APM track. And so they're predicting that more people will move to that track. It's still unclear whether or not that's true or not. And then they also said that there is a threshold by which, if you're not a large participant in the Medicare system, you will not need to qualify for either APM, advanced APM, or MIPS. And that threshold is if you're a practice billing less than $30,000 a year to Medicare, or you're providing care for less than 100 Medicare patients, you don't need to worry about either advanced APM or MIPS. So that's the first thing you need to figure out, is what track do you want to be on in this new system. So let's drill down to some more detail about MIPS. So MIPS is going to be a multifactorial scoring system. There are 4 phases. There are 4 boxes or 4 buckets that they're going to measure. They're going to be quality, cost, advancing care information, and improvement activities. So quality is an extension of the PQRS program that we're all familiar with. It's been in place. The cost is a new component that they're going to be measuring what the cost of your care that you deliver is. Advancing care information is the old meaningful use. So it's been decreased in its impact and it's been streamlined. And then improvement activities is another new concept where you have to do a process improvement activity to qualify for that segment of your score. So these 4 things will make up your MIPS score, and they're going to put it on a scale of 0 to 100. And then on this slide we show in 2017, again the starting year of this new program, where the measurement's going to affect your payment in 2019. The four components are listed there. Now what they've said is, first of all, the cost component will have a 0% weight in 2017. So they're not going to be measuring, or the cost of the care will not have an impact on your score in 2017. The vast majority is going to be on the quality score, and there'll be a 25% impact for the old meaningful use, now called ACI, and 15% will be based on your quality improvement activities. So you can see the progression from 2017, 2018, and 2019. The biggest change is in the cost component. It's going to go from 0% impact to 10% impact to 30% impact by 2019. And the advancing care information and improvement activities will stay the same across the board for those 3 years. So that is how the scoring will work. It's also important to know that they plan to make this budget neutral, and we'll talk more about that in terms of what that means. What it means is the lowest performing people will suffer a payment penalty, and that payment penalty will be used to fund the payment bonus for the top 25%. And so that's how they're going to keep it budget neutral. The other bullet that's on this slide that I think is important to know is in addition to your payment that you'll receive from CMS, they also plan to publish the rankings of the participants. So your score in this game will be published, and the public and other payers will see and know the rankings. This is likely to have a larger impact than just the financial impact of the penalty and the incentive program. So that's an important part that we need to make sure people are thinking about. On the next slide, I talk more about how this publicly available ranking and score is going to be displayed. Again, many people believe that this impact is going to be more important than even the payment penalty or incentives. Because, again, as a physician, my experience is we're all very competitive. Nobody likes to be at the bottom of anything. And so this is going to be an issue for physician practices, because patients may look at this, other private payers may look at this. This may have an impact on patients' choice of who they go see. It may have an impact on the contracting that private payers make with physician practices. So while the number of 4% negative penalty may not seem that large, we have to be thinking about what the impact of this publicly available rankings will have on that. So let's move to the next slide. As I said, this idea that we are going to start a new program at CMS where the scores are going to be kept starting January 1st, 2017, and those scores are going to impact how physicians are paid in the 2019 year, and the rule book for that game is just being published in the middle of October, 90 days before the start of the game, it makes it very challenging for physicians' practices to get ready to be optimally ready to play this game. And so in recognition of that, Centers for Medicare and Medicaid, the acting administrator, Andy Slavitt, he announced a new program called Pick Your Pace for 2017. So Pick Your Pace is described here on this slide. Again, advanced APM participation. Again, that is, if you choose to go that way, that has implications. Remember that advanced payment models or alternative payment models involve taking on risk. And that is an important thing to think about if you're considering that track. Taking on risks takes a significant amount of sophistication on your part as a practice, because if you predict incorrectly and you're putting some risk into this, or taking on some risk in this, that can have significant financial implications to the practice. And so that's not something you want to do without full knowledge and preparation, because the risks that you take on can be substantial. So I want to turn my attention now to the MIPS part of Pick Your Pace, and they gave people 3 choices. You can be at test pace, partial year, or full year. Now test pace is about as low a bar as they could make, right? In test pace, all you have to do is submit something other than your signature. So, you know, if you submit anything in the area of one quality measure, one activity improvement, or any of the required measures in advancing care information, the old meaningful use, you will avoid getting a negative payment adjustment in 2019, right? So pretty much you have to work to get a penalty in 2019 the way this is working out. Because if you don't report anything, that's the only way you're going to get a negative 4% payment adjustment in 2019. So they've tried to make it pretty easy. You know, the minimum score is 3 to avoid a payment penalty. 3 out of 100. So that's a pretty low bar. The second option is to submit for a partial year, some period of time, at least 90 days. If you report on something during that time, you may qualify for a small positive adjustment. And then the third option is full year reporting. And that's where you report for the full 90-day period or a full year, and there's differences in how that reporting works. But if you do the maximum reporting on the maximum things, you may well be in line to get a positive payment increase in 2019. So as you can see, CMS has tried to be responsive to the concerns that the game is starting very soon after the rule book gets published. Now, the thing I will say about Pick Your Pace is that we should not take Pick Your Pace as don't worry about it and you can be complacent. What my message to people has been, don't be complacent. Use this time that CMS is giving us to get prepared for 2018 when the real game and counting starts, because it would be a mistake to get behind in this process. I've recently been quoted to say, you know, it's when we were medical students, we had a very, very heavy academic load, and no medical student wanted to get behind on a class because it's very hard to catch up the night before your histology exam or your renal pathophysiology exam. That's not something you want to try to catch up on the night before the test. The same thing here. Don't get complacent about MACRA during 2017 because CMS has relaxed the rules and about this Pick Your Pace program. Use this year to prepare for the test that's coming in 2018. So on the next slide, I talk a little bit about how all this results in payment, because I know many of you are actively involved in your physician's practices from the payment and billing side. This is a fairly complicated slide that builds, and so I'll go through it a little bit. The first thing to say is that there's going to be a performance threshold, And people that do well on the top half can hope to qualify for up to 4% increase in their payments, and the people that are at the bottom 25%, can face up to a 4% penalty. And those ranges expand over the years 2019, 2020, 2021, 2022. So as you can see, the upper threshold grows and the bottom penalty threshold grows simultaneously. And so that's important to know that, you know, as we get started, it starts slow and not too painful, but it expands pretty rapidly from 2019 to 2022. Now this is an improvement over what we projected at the AMA. We thought that if nothing happened with the SGR, that physicians could be facing up to a 19% penalty, 14 to 19% penalty in 2019 if everything went against them. So this 4% limit is actually a big improvement over where things were before the SGR appeal happened. If we just change the next slide in advance and show how this progresses, they're also talking about a three times bonus for the very top performers. So while these numbers of going from 4 to 5 to 7 to 9 seem modest, if you add the 3x multiplier, that can be a substantial increase in the revenue for the top performers. And so again, I go back to my point that, you know, everybody should be looking to try to be in the top 25% or even higher top percentage to qualify for these additional bonuses. And so that's going to make it critical that you do that. So these numbers look something like the threshold. Let's just say the threshold at 70%. So if you get 70 out of 100 points, you may qualify for, at the beginning, a 0.5% additional performance threshold. But as you get closer to the top, you may get an additional 10% on top of that. So these are important numbers to be looking at. And again, the whole idea is to get people incentivized to strive for being in that top percentage. But remember, it's a curve. Not everybody can be the top 25%. So somebody's going to have to be in the lower part. And what I'm trying to make sure is that everybody's working hard not to be in that bottom percentage. The other thing that's important to know about the program is that the threshold to avoid negative adjustments goes up every year. And so, you know, there's a threshold set for 2019, but the threshold in 2020 is higher than 2019, and it stair steps up like we're describing here in this slide 15, where each year the floor rises. And so you have to keep up. You can't just stay steady state, or you'll fall even further in the negative territory. So the performance threshold raises every year, again, reemphasizes that concept that you have to be prepared for this process. It's going to start in 2019. And so with the next slide, we show that I'm going to start transitioning here to my partner, Lisa, to talk specifically about the chronic care management code that they put out. But I thought I'd give you all the background on MACRA, the history of it, where it came from, how the new rule book has just come out, and how critical it is that physician practices begin to prepare for 2017 and, more importantly, 2018. And with that, I'll turn it over to Lisa Esch, and she'll take it from here.
Thank you, Robert, and thanks everybody for being here. So we're going to switch gears a little bit, and Robert did a great job really painting the picture of the landscape today and the impact of what we're seeing with MACRA. And that really is, there's a lot of fear out there about it. There's a lot of anxiety around it, and especially because we know the look-back period begins January 1st. You know, we're just a few weeks away from when that look-back period starts. So what I want to do now is, as we move into this discussion around CCM, really paint the picture for you and give you a better understanding of how this can really be the foundation that you build in your practices to be able to not only just survive MACRA, but to flourish under it. And we're pretty excited about the possibility for practices, particularly the small, medium-sized practices, even large practices. You can be more successful from a standpoint of payment and when you're aligned with quality under MACRA than you can today, than the current payment structure. So at the end of this next section, hopefully you'll see that that's the story that we paint. We show you the foundation that you need to build. In order to do that, we're going to share with you some lessons learned, some things we've heard from across the country about, you know, why it didn't work and where people who are trying to do this themselves are struggling. So that's what we're going to walk through. But for those of you who don't know that much about Medicare's CCM program or chronic care management program, it is really tied to the CPT code 99490, and I know our audience today, many of you are coding experts, billing experts. You may or may not have seen this code come through your practice. And so just to kind of get a review about what it is in case it is new to you, I want to just walk through that right now. So beginning in 2015, Medicare began paying for non-face-to-face care planning and coordination around patients in the outpatient setting for physicians and other providers. So basically, for the first time ever, CMS recognized that, you know, physicians spend a lot of time managing their patients outside the four walls of the office, and they are hoping to coordinate care naturally when they're in between office visits, and that takes a lot of time. So they designed this code to start reimbursing and building the foundation for care coordination in a physician's practice, and it is that monthly non-face-to-face time. It requires 20 minutes of time, and it's for patients with 2 or more chronic conditions. And just a couple things to know about that. We often get asked, well, can you send me the list of conditions? How do we know who qualifies? CMS actually left this undefined in the sense that they give you the top 25 conditions that most patients have, but a physician is able to define the chronic condition if it lasts more than 12 months and has a profound impact on the patient. So that's actually where the beginning is with CPT code 99490 and care coordination. And that 20 minutes of time isn't just time spent by the physician. It can be nursing, MAs, and other interactions that happen around the patient. But it does need to be documented, and I'll talk more about that later. So with that, I think we actually go to a polling question. So we're really curious to see how many of you are participating in Medicare's chronic care management program. What are you seeing out there? We'll give you a couple seconds to actually reply to that. All right. So with that, I'll just share with you what we're seeing. We're seeing about 19% of you have participated, and 80% have not participated in CCM. So that actually gives us some perspective as to how we'll kind of cover the next few slides then, because most of you are not familiar with it. So that's great. We can fill you in on what it all means and how to work with it. So with that in mind, CMS had some very, very specific goals in mind when they launched CCM. It actually came out of the Innovation Center for CMS, where they did a pilot for something like 12 to 18 months, and they specifically did care coordination for patients who had 2 or more chronic conditions. They spent the providers spent 20 minutes a month documenting that and engaging patients, and they found pretty quickly over the course of that time that 2 things happened. Patients actually had better outcomes, and secondly, they had a reduction in avoidable events. So they reduced things like urgent care, ED, and hospitalizations. So it managed the cost issue that they're struggling with, and it actually impacted the outcomes. So when we look at what the goal is, this really aligns with what CMS is trying to do as they walk everyone through how do we get to value-based care? And Dr. Wah already spoke about the goals, pretty strong goals of what percent that they want to see that, and this is how they're going to do it. So it is that ongoing care management. It's what happens between providers and settings. It's what happens in the care transitions. You know, there's a lot of care that happens in the home, in the community, outside the physician office, outside the hospital. The coordination of care is complex for some patients. It's very time-consuming. Patients with 2 or more conditions can have multiple physicians. They can have 4, 6, 8 doctors that they're trying to coordinate. Having a really patient-centric care plan that includes all that information is really a very high priority and probably a foundational piece of how we move to value-based care. And then we also have just all the different system-based approaching. We have MedRec oversight, and that's a piece of that strategy to move to value-based care. And then we also have the effective use of health IT. So it's really important, and one of the components and requirements around CCM is that it is a meaningful use 2 certified EMR in the physician practice. Currently, it does exclude electronic exchange via fax. That changes in January, and there's other elements around that. So they wanted to take care management, care coordination, and IT and bring it together and really build a program that helped providers move to this value-based space that they want everyone to. So along that line, Dr. Wah mentioned earlier as well that there was this 900 and some page document that came out and had a lot of complex rules around it, and that was really supporting the strategy of going from this fragmented care concept to moving forward. So currently right now what we're seeing is a very fragmented care strategy. Patients are in and out of different systems, they're seeing different patients, there's no communication with it, and it really is, it can be very disconnected for the patient and disconnected for the providers. So from there, in order to really move into population health, we do need to have that foundation of coordinated care. So the coordination really puts the patient in the center, and it's really providing the infrastructure around them to help them learn new ways of interacting in the healthcare system, as well as the physicians and the providers interacting with patients in a different way, because now care's been expanded to outside the 4 walls of the office, and that's new. And all of that really takes us to a place that is the ultimate goal of full-on population health, which is technology, it's people, it is this broad base and this broad concept around population health. We'll go to the next slide. All right, and one of the things too that we saw, as I mentioned, that Robert had mentioned, the big document that came out this summer, is just in the last few weeks we also saw a simplification of the code that was announced. So when CMS put this out in 2015, it had some pretty high requirements for electronics, for time, for patient enrollment, all very, very specific requirements that made it pretty cumbersome for physicians and practices to be able to engage around the new code and actually building that infrastructure to move to value-based care. So what we saw in the first year was we have over 50 million Medicare beneficiaries, but even as of this spring, 275,000 patients had received benefits from this service. So it really didn't have the uptake that they needed to see or that they wanted to see, so CMS did respond by loosening those requirements. And so that's really good news for those that haven't tried to do this on their own, but it's also good news for those who are doing it and are struggling. So there's some key differences that we see now with the new rule. And just a couple of those highlighted right now really are the fact that the enrollment process itself has been very challenging for patients and for physicians to get the patient educated and consented. Currently, it takes a written consent in the office, and there's a form that a patient has to fill out and they have to do a written consent. And that is changing. So in 2017, it's much easier. You can enroll patients through a conversation over the phone, in the office, if they're there, or just as you're engaging with them, you can inform them that way, and the consent can just be something that the provider does document. Another area that was a little challenging for patients is, there are a lot of patients who have very complex medical history and do take more than 20 minutes. So CMS is expanding on the billing codes that allow for not only just the 20-minute visit, but now they allow for a 60-minute visit and then a 30-minute increment after that, or not visit, but interaction. A 20-minute coordination engagement, 60 minutes of care coordination, and then 30-minute increments after that. So these are not visits. They're not in the office. They're outside of the office and not face-to-face. And then the other piece that CMS recognized was pretty burdensome for practices is the communication of the care plan and documents through the electronic requirements. So CMS has reduced those requirements as well, and now allows for faxing of documents as an option for practices to communicate back and forth. It's not ideal, they recognize that, but it is a pretty necessary way to communicate in the future. So our next poll question is, what percentage of your CM patients enrolled each month do you typically engage with? So we had about 22% of the people who are actively doing CCM. So when you think about those patients as you're billing for them, how many of those are actually billed on a month-after-month basis versus just occasional? What's the consistency look like? And we'll give you just a few seconds here to fill that out, and then we'll fill you in on what that looks like. All right, so right now we're seeing about 60% of you say less than 20% of your patients are actively engaged month after month. We have about 12% that say 20 to 40, 15% say 40 to 60, nobody over 60, and nobody over 80. So the max is that 40 to 60. Most people are having less engagement. And I can just tell you that's what we're seeing here. This is what we hear from practices that are trying to do this themselves as well, is that it can be very challenging to keep patients engaged month after month, and the value behind that. So, all right, we're hearing that as well. We'll go to the next slide. So I want to talk a little bit then about maybe why you're having some of the challenges that you're having. And some of the things that we've learned is that most CCM programs focus on two aspects of care coordination. They focus on the people and the technology. So most of you have staff. You have an MA, and care coordination is really about logistics. It's about care plan adherence. It's about gathering information and helping the patient navigate healthcare. They're making sure they're with their visits, the follow-up, and that type of thing. It's not clinical disease management. So most practices have the people to do that. In a limited capacity, they might have one MA, or they may have an MA assigned to doing this kind of work in engagement with the patient. And most have some sort of technology. They have an electronic EMR somewhere that can capture some of this information for them. It may not be robust enough for them to meet the documentation requirements that CMS does require, but they'll have some sort of technology. What we found is that the most successful CCM programs actually have a third component built in, and it really is the clinical guidelines and workflow. And this is where it takes more than just taking a patient's phone call and answering a question and documenting that in the chart and calling that care coordination. It really is thoughtful and purposeful interaction with patients. It's outreach. Reaching out to them, scheduling time to engage with them specifically about the diseases and conditions that they have. with interactive workflow and clinical guidelines with that. So that's really a key that we're finding, that it takes more than technology and people to really drive the retention that you want with your patients and get any kind of success. And for CCM to be successful, it really does need to be at scale, which tees up the next slide. So a couple things that we have seen, particularly around the patient workflow, is how does a provider, how does a physician, the nurse, the staff in the office talk to the patient about CCM? It's kind of it can be an awkward conversation, and so we actually have found that when we coach and help script this dialogue and interaction with patients on behalf of the practice, it really helps with the enrollment and the engagement and the long-term success of the program. So we found there's 2 or 3 key ways of communicating the value of this, and the patients then enroll in the program and stay committed to it. So having that enrollment process, it becomes part of your workflow, and part of the workflow that you have with the patient that isn't intrusive, that isn't just another thing they have to sign. It really is purposeful, and there's value around it. And then the other part of the workflow that's really important is that when you have CCM as part of the engagement with the patient around managing their care, 20 minutes every month of interaction with a patient can really begin to accumulate a lot of information. And whether that what do you do with that information? What part of it belongs in the chart? What part of it's just nice to know? And what part do you really need to know? So that gathering that information and getting it back into to the provider so they can find value and meaning out of it is just as important as the engagement is with the patient. And then we move to really the clinical guidelines. And we feel like this is probably the key to driving a successful long-term CCM strategy. So again, CMS put this program into place to build the foundation for the infrastructure and the foundation to really help practices and providers and physicians move to value-based care. And so it really, a successful CCM program really does need more than just recording what providers or how they're interacting with a patient. It does take the clinical guidelines and a meaningful dialogue with every patient every single month. So the patient has to feel like they're getting more than just than what they're getting currently, and adding that extra value is really, really important. So having the scripted dialogue, having dialogue that is designed to work with the protocols and the workflow is really a key element of this. And then having very consistent, high-quality care that impacts MACRA performance. So this is one of the things that can be a real differentiator for practices who are doing CCM now, or who are going to be doing it in January when the look-back period for your MIPS adjustment begins. So normal CCM, if you think about just capturing the workflow and capturing what you're interacting with the patient, that is not necessarily going to align very strongly with how physicians and providers are going to be scored under MIPS. But with crafted clinical guidelines, we can, and we do this with our partners, we actually address and align our scripting to go with what the practice is being measured on. So if if you need to do fall screenings as one of your measures, we build that into our scripts. We're making sure we're doing that along with you, and that we've got the documentation to help you hit that quality measure and actually do that work with the patient. We're working with another provider right now. The Medicare patients are surveyed, and they're often asked, did your doctor talk about fall prevention with you? Did you have education on this? There's multiple things that they ask the patients about, and the patients sometimes forget that these conversations happened in the office. So what we do is we can align our scripting with your patients as we begin to know that call time is coming up and that the surveys are coming. We can script that so our engagement with the patients aligns with the survey to remind the patients that has been done, that it has been completed, that you're going to get a call, and it's okay to, that they can recall that. So we help support the strategy and the efforts that go in around the clinical guidelines to map them to what is important to a practice, and so it aligns with the things that you're being measured on. And as Robert had mentioned before as well, physicians that do something now can get ahead and be on that path to actually, be above the line, so they can possibly qualify for the bonus part. But also those that are in the top 25% of performance will actually have added incentives in place as well. So there's a lot of, there's definitely a lot that goes along with the value of this. So the next question is, have you experienced patient retention issues with your CCM program? All right. So it looks pretty similar with the last poll as well. It's 16% yes, 78% no. Actually, it's 78% no. So it looks like the patient retention issue hasn't been as much of an issue as the consistency has. So that's good to know. And with retention, it really depends on how long you've been doing it and how you're engaging your patients. So that's a key differentiator as well. All right, let's go to the next slide. Well, so to address some of those issues that we've talked about, some of the challenges around CCM, the gathering the care plan, communicating it out, the workflow, the enrollment process, we've actually put together a program that really addresses some of the challenges that we've seen in the marketplace, and it really addresses why we've seen such a slow uptake. And the first really key part of this is having a coordinated, dedicated team. And what we're finding is that when you have dedicated MAs for your practice that work alongside you and with you to support this, it really does make a difference in the engagement that the patient has and the experience for the practice. And a lot of practices are hesitant to not have somebody in the office be the one that engages the patient. And we try to overcome this by providing the staff that does that, and we do this electronically. We do it is remote, and we do it by phone. We are engaging patients by phone. But the key here with the coordination of the team is that when we stand up a practice to do this, they're not going to get just a phone bank of MAs. The coordination center and the teams are put together in a way that a practice is going to have consistently the same MA, and the patient's going to be assigned one MA as well. But also a key to this is our teams are led by RNs, some BSNs, and we're adding pharmacy tech as well. So the teams that actually manage these patients are seen as an extension of your practice, and we've put that together so it's a very positive experience for the patient as well. When we look at the process, a couple of things that differentiate us as well is one of the things that we found is that when MAs are engaging patients in care coordination, a lot of times they're not trained or experienced really in how do you have an active relationship and ongoing engagement with a patient over the phone. You're not seeing them face to face, and it certainly is much more than just what a typical MA might do in an office of greeting a patient, weighing and measuring them, and moving forward, walking them through that whole process. So we do extensive coaching and training with our teams, so they have the behavioral engagement the behavioral coaching and experience to be able to engage patients over the phone. We also drive engagement through digital channels when that's appropriate. Some patients want digital, some patients don't. We have very rich, deep protocols that are dynamic, and so our MAs aren't just left to try to figure out what to say and do with the patient. We actually guide them in that interaction. We track the CCM activities by the second, so that really helps to create an audit-proof process for you when you look at how, what's going to happen, how do I track this, how do I document that this work was done. And we also build in educating the practices to all the different changes. So we have WebExes, and we really want to be a partner with practices as everyone's trying to figure out what the changes are around MACRA and CCM, and from there. And then with the when it comes to the patient, we really want this experience for the patient to be added value, and that they sense that they're getting more through this program than they would by not being in it. It's very high tech, it's high touch. We have very targeted health messaging. We try to work with the community resources that are available to help support patients that have to navigate complex parts of the healthcare system as well. So there's a lot going on with CCM, and there's a lot of opportunities to have it not work very well. And so we've put together this program that really does leverage the best of the people, the technology, and the clinical guidelines to put that focus on the patient. We'll go to the next slide. All right. So when we think about how now to leverage CCM to target MACRA performance, we're going to shift gears here a little bit, because MACRA is going to have a huge impact on physician reimbursement. And what's key about this is with CCM, it really does help subsidize the investments that practices need to make to move to this value-based care infrastructure. And again, you've seen elements of this, the quality, the cost, the advancing care information, and the improvement activities. These are the buckets that physicians are scored on, again, and 100% of their Medicare reimbursement rates will be tied to this starting in 2019, with the look-back period beginning in January. So that's really a key part of it. And of the MIPS score, one thing to keep in mind, again, is that quality drives 60% of the score in 2017 in that look-back period of time. So it does shrink down to 30%, but right now it's 60%. We wanted to kind of give you a snapshot of how our point of view on how CCM satisfies the MIPS measures. So when we think about who's going to be in MIPS and who's going to be in the advanced APMs, in year one, it's estimated that between 85 and 95% of providers, physicians, are going to be under MIPS. So even if you're in an MSP 1, and that's an ACO, you'll still be under MIPS. So this is really where the focus needs to be. And while CCM alone does not satisfy like the quality measurements, because quality measurements need to be tied to protocols and purposely interacting and doing things with patients, we've put together a way to connect your quality measures with this element of the score to help really have physicians be successful under MIPS. So the different categories, and this is just a snapshot, guys. There's a lot of information out there. We've just pulled a few of the top categories we think are relevant and kind of the easiest ones to tackle right off the bat. So care coordination, that patient caregiver experience, top health and prevention, and efficiency and cost reduction. Those things can be measured by the care plan, the documentation, the treatment plans, and different education to the caregiver. So we align, we can again align the workflow and the interaction purposely with the quality measures that a physician would pick that they want to report, because the physician does get to pick those measures. The next area again is clinical improvement. And again, from the care coordination, POP management, and beneficiary engagement, there are multiple ways and measures that CCM connects to clinical improvement. And as a physician looks at how am I going to tackle this? What can I do? You know, CCM implementing this really helps align them and start getting that foundation built so they have an infrastructure to be successful here. And the next bullet. Advancing care is, again, just a new name for meaningful use. It's been rolled up into this section, and it is a component that even CCM can satisfy. So the part that connects here is if you have access to different patient information, sending documents through secure messaging in that care plan, that actually helps you qualify for this section of the MIPS score in 2017. And again, there's a lot more around this. These are just a few highlights that that can kind of give you an idea as it's very, very impactful, and you can start these now. So you're probably wondering, gosh, I may be trying to do CCM in my own office. We've got somebody dedicated to this. They may be doing a few patients a month. But what would you do with my patients that I'm not already doing? So this really is a slide that kind of reviews that. It's more than just capturing what you're already doing. It's having that thoughtful, outbound, and relationship with the patient where there's coordination, communication, and really building confidence around the patient. And this is so much about the patient and improving their outcomes and keeping them engaged and empowered to actually manage chronic disease. So capturing that circle of care, these are just some of the things that we do that are requirements for you to actually bill CCM. So these are the things that have to be done on an ongoing basis, a monthly basis. And we capture that in the engagement and the circle of care as we develop that care plan. Creating that care plan, a lot of times physicians, primary care physicians, they may have a list of conditions, they may have some medications. We take, even if they have a care plan, we take that as a place to start, and then we add additional information to it through our engagement with the patient and other providers to provide a more centric and robust care plan for the PCP to review. Go to the next slide. All right. So this is where we want to sort of give you the picture of how do you really double down on MACRA with CCM. So again, hopefully you've seen that there's an immediate financial benefit. You can actually, when you do it right, when you do the 20 minutes, you document it, you have that care plan, and you have the electronic medical record. When you have those elements in place, you can actually bill for this code. And the average reimbursement rate is about $40 across the country. It's going back up to the original value. It'll probably be more like $42 in January. And so you've got those CPT codes that you can actually bill for this work. And additionally, we have the new codes to even be able to bill for additional time that's spent with the patient, those 60 minutes and then the 30 minutes after that. So there's an immediate financial benefit to putting CCM in place, let alone we're all doing this to drive better outcomes for patients and reduce cost to the overall healthcare system. But the next part of this process is even more significant. Is that when you look at what's going to happen in 2019 with the MACRA and the payment adjustments and that look-back period which starts in January, but by putting CCM in place, you get the immediate financial benefit of building this infrastructure and having CMS funded for you, but you reduce your risk of the payment adjustment that you will take in 2019 as a provider. So physicians, again, will have either a minus 4% or a plus 4% as the first adjustment in 2019, and that goes up to 9% adjustment negative or adjustment positive. But also by putting CCM in place, we're excited because we really see the potential and the value of this, that it is the foundation for you to not only just not take the negative payment adjustment in 2019, but if you do something now, and many are doing nothing now, or they're just doing a little bit now, you'll be a lot further ahead and on that road to possibly being in that top 25th percentile for performance and qualifying for even additional bonuses. So taking that initiative to do something now really is key. But one thing to keep in mind is that CCM is meant to have the impact that it needs to have on quality and outcome for your practice. You really do need to do it with all your patients that are qualified for it. So if you think about your Medicare population, your fee-for-service Medicare population, you probably need to be consistently delivering CCM services around about 80% of those patients to have the most impactful strategy around this and to have the biggest impact on performance. So getting 10 or 15 or 20 hit and miss every month typically is not going to have the impact that's required. And to be able to do this on your own, to hire the staff, to hire the MAs, train them, build the workflow, build the protocols, that's pretty daunting for most practices. They don't have the financial ability to hire more staff, deliver it, and then get paid later. And so that's really where you probably want to consider bringing on an experienced partner to do that. And we can talk more about that if you are interested as well. I think that takes us to our last slide here, which is hopefully that this has been a good education session for you, that you've learned something about MACRA, MIPS, advanced APMs, that you can see how CCM can be the foundation for your success under this system, that you can really improve patient health. You can certainly improve patient experience through this. It can impact your performance under MIPS and what your score and the financial impact is going to be. When you come alongside the right partner, there's minimal distraction to the practice, and really there is a substantial revenue opportunity for you that goes alongside helping to improve patient outcomes. And we, happy to talk with you about how we can work with you on that. So with that, I think we are going to open it up to questions. So let me see what we've got here. Okay, that's great. So thanks, everybody. I appreciate the time. Now we're going to kind of tackle some of these questions that we have here. Robert, do you want to go ahead and get started?
Lisa, I thought I'd start. There was a couple of questions about the MACRA program, which we can entertain. Obviously, there's going to be a lot of questions about MACRA. We could spend all day talking about it. But there were a couple of things that I think are worth thinking about. One was a question about the joint replacement program. CMS put out a new program to pay a fixed bundle payment for a comprehensive joint. They have announced that for 2018 that will be considered an advanced payment model. So that is in the works, but it won't qualify in 2017. There was another question about the cumulative nature of the bonus, and it gets into a little bit detail, but the way, and again, I'm probably not perfect on this because I'm just a doctor here, but the idea that if you get a 4% bonus in 2017, does that raise your baseline and you get a 7% bonus on that 4% bonus the next year? I don't believe that's true. I think there's probably a new baseline every year for the codes that CMS puts out. And so if you achieved a bonus on the 2017 codes, you'll get a bonus on the 2018 codes as opposed to being able to lump your bonus from 2017 onto your 2018 payments. But that may need a little bit more research. There is another question about whether, and then I think the rest of the questions that we want to spend some time on are talking about the chronic care management program, because as Lisa said, first of all, we think that there's a huge opportunity to expand the use of this code that practices are not currently doing, and the value of expanding the use of the code is better care for patients. As a physician, first and foremost, I'm interested in that. The patients, I believe, will have better care if their care is coordinated using the chronic care management system. And second, physicians will recognize new revenue that they're currently leaving on the table. And you all that are financially related to your practices will recognize the value of an additional $40 per month per patient in your practice. That's a significant increase in revenue streaming into the practice. And also, very importantly, is by using something like the CCM solution, you'll get the business process and the workflow in the office to start utilizing capabilities that exist outside the four walls of the office. And we believe that that's going to put you in a good position to be very competitive in the MIPS game going forward. And so why not have CMS pay for that foundational element to get your office ready to be very competitive in the MIPS area? So some of the questions that came across in the CCM are about the idea that can a hospitalist code for this? It's important to know that CCM was developed for one primary care doctor for one patient. It's not every doctor that treats a patient with chronic illness. And this is obviously a way, and this is why the enrollment process was so critical, because CMS isn't going to pay every doctor who touches a patient with chronic illnesses, because they would, there'd be double dipping here. So it's one physician per patient, and once a primary care physician enrolls that patient, no other primary care physicians can bill for that code on that patient, and it's not meant for everybody who deals with that patient. Another question that came up, I think that was critical, was this idea that there is a high hurdle to be able to qualify for billing under chronic care management code, and one of the concerns was that the patient has to enroll. We talked about that. There is a copay that the patient will have to pay. So all Medicare codes carry a 20% copay. And Lisa, do you want to address the copay issue real quick?
I certainly will. So this is considered like a visit, even though it's not in the office. So that's part of what the explanation of the program is, and the patient consents to that. So we're seeing a couple things. We're managing a couple practices that did this on their own and didn't do it consistently or well. And the patients really didn't feel like they were getting added value about it, and they complained about the copay, and some of them didn't stay in because they're like, why are you charging me for what I was getting for free before? So that's a fear about that. What we're finding is that with the right conversation about the program, and when we're providing the service, there's so much added value to it that we're helping the patient takes our call, they look forward to it, they schedule the interaction with us. There's so much value around it that we have very little pushback on the copay at all. So that's not been our experience, but we do hear that from providers who are trying to do this on their own, and from other providers that aren't necessarily driving the same type of engagement that we are. So it's out there, but the patients are willing to pay it because there's a lot of value in it, and they're getting a lot out of it. So right now, that's been one of the issues. There's been so much pushback, though. CMS recognizes that part of the hurdle of rolling this out is that there's the copay to it. So if a patient has secondary insurance, you bill your Medigap insurance, they're picking up the copay. That those patients don't have to pay the copay, then it's covered with Medigap. And CMS is aware of this, but it will take an act of Congress to get the copay waived. So that's where it's at right now. And there's another question in here that has to do, it was explained to me that in order to use this code, the patient must sign consent, and that is correct, and that the provider must be available to speak directly to the patient for questions on a 24/7 basis. Is that correct? So it is and it isn't. They have to be on call, so if a practice is on call, that covered it. However, this requirement changes and it goes away January 1st. So that big hurdle about 24/7 access to the care plan and the provider, this is not acute disease management. This is chronic condition management. So CMS has waived that requirement going forward. Let me see if there's any other questions down here that I can answer.
So Lisa, while you're looking at the questions, I guess I'll just reemphasize the other part of the thing that you mentioned was that we crafted this CCM solution so that there is no additional risk to the physician office, because many physicians were telling us that they were concerned about having to hire extra people that may not be fully utilized if they wanted to go into CCM on their own. So we built this in a way that there's no upfront cost by the physician. Once they sign up with us, they can be ready to bill on that new code within 3 weeks after signing up for the program. And so it's a turnkey solution that brings additional capability to their office that's related to their office. Our coordination center is not labeled CSC, it's labeled Dr. Wah's Coordination Center. So when the patients are interacting with our coordinators, they are seeing essentially an extension of Dr. Wah's practice, not CSC. So I want to make sure that was important to get across as well.
Yeah, thank you, Robert. That's great. It's a good question. There's a question in here about in order for a provider to bill CPT 99490, do they have to document what type of CCM they are doing? They do. So there is the oncology care management. There are some other codes. This is specifically 99490, which is care coordination. And there are regulations around like what has to be documented, what kind of interaction with the patient qualifies. So if you're, there's certain things that don't qualify for it. It's not clinical disease management. So there are a list of qualifications in order to be able to bill for 99490. And that was saying, I'm asking for a health plan. We review medical records. So a health plan would need, a health plan is, this is a program that's paid for by Medicare, so the plan would have to be a Medicare fee-for-service plan in order to bill for 99490. All right, let me keep going down. Robert, did you see any other questions you want to tackle here?
Well, some people have asked, this is new information to them. This program has in fact been in place for a little over a year and a half. That was what caught our attention, as I think Lisa might have mentioned. $40 a month is a significant new payment for practices, and yet there was a very, very low uptake of the program. Less than 100,000 claims are submitted in the first year. And that's why we crafted our solution to try to figure out how can we make it easier for practices to add this to their practice, because it does result in better care for the patients, new revenue for the practice, and it does get them ready for MACRA. And so that's the whole purpose of us crafting this solution, was to make something that people could take on without additional risk, like I said, no upfront costs, and immediately start driving new revenue that the practice didn't previously have. But most importantly, starting to improve the care for their complicated, chronically ill patients. So yes, this has been in place for a while, this non-face-to-face reimbursement.
All right. Well, I think we've covered most of the key questions, and we're at the bottom of the half hour, about the hour here, so we probably want to wind this up. And if there's some other questions in here that didn't get answered, you'll have our contact information. Feel free to connect with us. But thank you very much for your time.
There were questions about the slides being available, and I think they will be available, so we can know that.
All right. Great.
Yeah. That does appear to be all the time we have for today. Dr. Wah and Lisa, do you have any final remarks, or would you like to provide the audience with your contact information?
Absolutely. So I'll share my email address with you. It's lesch2@csc.com, and we'll put this in the slide deck as well. And feel free to email me if you'd like any follow-up information, and I can reach out to Dr. Wah then as well. So thank you.
Thanks, everybody. Like I said, get ready for MACRA. Don't wait till the last minute. Look at the CCM program as a way to get ready for that and get your office ready to participate in a practice that's going to be competitive to be successful in MIPS, as well as improve the care for your patients and drive new revenue for your office.
Great.
Thank you. I do see questions such as, will there be a handout? Yes, as Dr. Robert was saying previously, we will be sending out handouts, a PDF copy of the presentation, along with 1.5 AAPC approved CEUs. I know this was a lot of information to digest in one sitting, so This presentation was also recorded, and you can be on the lookout for that on our YouTube channel, youtube.com/Advize Health. You can expect to see that up early next week. I would like to thank everyone for attending today's presentation, and I would like to extend a very special thank you to our two guest speakers, Dr. Robert Wah and Lisa Esch from CSC. Everyone, just be on the lookout for your CEUs as well as an announcement for next month's webinar within the next 3 to 5 business days. Have a great afternoon.